Good evening, everyone. I'm Dr. Kim Thornton. I am a reproductive endocrinologist at Boston IVF. I'm also the Director of Reproductive Endocrinology and Infertility at the Beth Israel Deaconess Medical Center. This is Facebook, or actually it's now Zoom Live, I guess, where we're going to talk about just different features of infertility, the evaluation, the treatment, and really answer questions that you guys have. So feel free to add them to the chat, and I'll try to get to as many as I possibly can. The first question that I received was, could I just explain the IVF process? So I'm going to give you a very high-level view of IVF. The purpose of IVF is to be very aggressive in terms of an approach to fertility. The indications for IVF include those patients with unexplained infertility who have failed more conservative treatment, those patients with tubal factor infertility, women with endometriosis where there has been inflammation or destruction of ovarian tissue or scarring in the pelvis, male factor infertility for those couples where the male has either low sperm count, low motility. We do IVF for couples who need to use an egg donor, or individuals who are undergoing gestational surrogacy, where you have to create eggs and embryos. So there's a number of indications for why we might do IVF. The process involves stimulating a woman's ovaries, and we do that by having the woman take medications, follicle stimulating hormone in particular, and those are injections that are given daily for a period of about 9 to 12 days. And during that time, we're monitoring follicular response so we can get an estimate of how many eggs an individual might be producing until the follicles get to a certain size. At that point, there's the trigger shot, which is either human chorionic gonadotropin, or HCG, which is designed not only to mature the eggs in the follicle, but also support the second half of the cycle, or the luteal phase. We can also use Lupron, which does cause maturation of the eggs, but doesn't support the luteal phase for those individuals who are doing pre-implantation genetic testing, for instance, of their embryos, or for women who are serving as egg donors. We then fertilize the eggs with sperm, either through standard insemination or a procedure called intracytoplasmic sperm injection, where we actually inject the egg with sperm to create an embryo, and typically culture the embryos out to day 5 when they reach the blastocyst stage, at which point we would plan to transfer an embryo back, or at that point we would do genetic testing of embryos and biopsy embryos. For those individuals who produce generally fewer than 4 to 5 eggs, oftentimes we will transfer embryos back at the cellular stage, so on day 3, if we don't know if their embryos will either go to blast, or if they don't have enough embryos, so there's not any benefit of carrying them out to blast to select a specific embryo. So that's just IVF in a nutshell. The first question that I see is, what FSH and estradiol levels indicate readiness for pregnancy, especially after undergoing IVF and other procedures like a myomectomy or hysteroscopy? I think this question is really getting at ovarian reserve testing. And ovarian reserve really gives us an indication, or is a way that we can assess a woman's ability to respond to gonadotropins and produce eggs. And so the tests that we do are an ultrasound with antral follicle count, normal levels normal numbers of antral follicles is anything greater than 10. We look at anti-Müllerian hormone, which is a glycoprotein hormone that is produced from the small antral follicles, and AMH levels above 1 are considered normal, but most women who have really normal ovarian reserve have AMH levels that are 1.5 to over 2. And then we look at FSH and estradiol, and FSH and estradiol levels on day 3 are not as sensitive of a marker, but in general, if an FSH is less than 10, I would expect that a woman would have a reasonably normal response to gonadotropins. And as the FSH level gets higher on day 3, the response is going to be less. FSH levels tend to climb in women as they get older, mainly because the number of eggs that are available for a woman to ovulate is reduced over time. So women, the same woman at age 30 who might have an antral follicle count of 15 might at age 40 or 42 have an antral follicle count of 2 or 3. And that's just a normal process in terms of reproductive aging. Likewise, that same woman could have an FSH when she was 30 of 5 to 6. At 42, it might be 9, somewhere in the 9 to 12 or 9 to 15 range. And so it just reflects the fact that the pituitary is responding to the fact that the estradiol production from the ovary is less, there are fewer follicles, and it has to work harder to try to stimulate an ovary that may be unresponsive. The second question, how does letrozole affect FSH levels? Letrozole is an aromatase inhibitor, and an aromatase inhibitor is a medication that blocks the aromatase enzyme, which is the enzyme that converts androgens, which are produced in the ovary, to estrogen. So if you block the production of estrogen, the pituitary senses that there's not a lot of estrogen around and tries to make the ovary work. And so in doing so, it increases its synthesis and secretion of follicle stimulating hormone. So the goal is to try to drive the ovary to produce a follicle. But it doesn't, letrozole or Clomid for that matter, doesn't fix the underlying issue that if there are no ovarian follicles in the ovary to respond, you're not going to improve the number of eggs that are produced. The next question is regarding pre-implantation genetic testing for aneuploidy. And the question is, does embryo grading matter if PGT-A testing is done? And I would say probably not. And what I mean by that is when we look at embryos that we biopsy, or the embryos that we would freeze, even if we were not going to biopsy, we biopsy the same quality embryos. So they have to, embryos are graded stage 1, or I'm sorry, blastocysts are graded stage 1 to 6. We will biopsy a blastocyst once it gets to a stage 3, as long as the inner cell mass, which is the group of cells in the center of the embryo, are graded grade A or B, meaning, and the grade reflects the size of the cells and how tightly packed they are. And if the trophectoderm cells, which become placenta, are graded A or B. So if you have a stage 3, 4, 5, or 6 blast, and the size, the number reflects just an increasing size of the embryo, further development of the blastocele cavity. If you have a stage 3, 4, 5, or 6 blast, that is a grade A for inner cell mass, B for inner cell mass, or the same grading for the trophectoderm, those are embryos that we would biopsy, and they're also embryos that we would freeze. I will be honest, and we've looked at implantation rates of these embryos, and they're pretty much similar if they're chromosomally normal in terms of which embryos implant. That being said, we choose the embryo with the best morphology first. So usually we transfer embryos that are grade AA first, and then we look at the size, those embryos that are larger. So the stage 6s are transferred before stage 4s, or 6s before 5s, before 4s, before 3s. But that being said, you know, I've transferred a 6AA that did not implant and a 3BB from the same patient that did, both being euploid. So I think as long as you have embryos that meet our criteria to freeze, whether we would test them or not, you have a good embryo. The embryos that don't do well are those embryos that are grade C for either the inner cell mass or trophectoderm. And probably the only exception to that is in very, very young women, it probably matters even less. So for instance, women who are doing egg donation, for instance, we will oftentimes freeze embryos from donors that are grade that have a C grade in the inner cell mass and a B or trophectoderm, because they tend to survive a little bit better. Another question: will IUI or IVF always be performed by the same doctor or rotated by different doctors who are available at the time? I think this really depends on the way a practice is structured, and I can speak to Boston IVF. Boston IVF has, as you guys well know, a number of physicians, and we can't all be in the same place at the same time. So in general, the physicians manage the cycles of the patients that are under their care, but retrievals and transfers are done by the physician who is assigned as either the doctor of the day performing retrievals or the doctor of the day performing transfers, with rare exception. And that's because we have a schedule that we have to meet, and I can't practice in Worcester, for instance, which is one of the offices that I see patients in, and do a retrieval in Waltham at the same time. All of our reproductive endocrinologists are board certified or board eligible, meaning that they're getting ready to sit for their boards. For the newer physicians, they're all very well trained. We track the statistics from the standpoint of retrievals and transfers to make sure that everybody's success rates are in the same ballpark and that there are no outliers. So it generally doesn't matter who is doing your retrieval or who is doing your transfer. There are some exceptions. For instance, if I have a patient who's had a difficult transfer and I've happened to take her to the operating room to do a hysteroscopy to learn how to navigate her cervix, I will schedule the transfer so that I can be available to do that. But I can't do that for every patient, and neither can my partners. We have meetings within our practice for difficult cases, so that if we have patients that are having difficulty conceiving, we have what's called a patient care committee, where we review those difficult cases and discuss them among ourselves. So, while you can switch from one practice to another, I think we generally have practice styles that are very similar. And when we're having difficulty, we are very willing to consult with our colleagues to get other opinions as to how a difficult case might be managed. Next question. A document says I can only use glycerin for sperm collection. What about lubricant for intercourse? It seems that glycerin is not recommended. You can use glycerin for having intercourse as well. There are some lubricants that happen to be toxic to sperm. So glycerin is one that's universally been vetted, and we think, when we look at sperm function after sperm has been exposed to glycerin, it seems to function pretty well. So I would stick with that, but you can use that for either producing the sperm through masturbation or when having intercourse. When embryos are frozen, is it possible to test them, and what are the chances that they make it? We can do what's called a thaw biopsy refreeze, where you thaw the embryos, biopsy them to do genetic testing, and then refreeze them. And especially if you have a lot of frozen embryos that have not been tested, you may want to consider this. I think you have to recognize, and one of our former residents did a study looking at implantation rates of embryos that were either not biopsied initially fresh and then frozen, or biopsied after a thaw biopsy refreeze. And the process of thawing them, biopsying them, and refreezing them does result in slightly lower implantation rates. But if you have a euploid embryo, the implantation rate is still higher than if you were to transfer the embryos untested. So there may be benefit to you as an individual. I tend to recommend thaw biopsy refreezes in couples or in individuals who have a lot of frozen embryos that are untested, who want to do the testing. I think that's where you might get benefit. I wouldn't do it if you had 1 or 2 embryos. Next question: financial support programs for IVF in Maine or in New England. What I would say, rather than talk about specific programs, is direct you to talk to the financial counselors that we have available at Boston IVF, because the answer that I give you may change depending on where you live. I know, for instance, we do have some foundation money that people can apply for grants. There are loan programs that we can give you references to. But again, I think I would talk to the financial or your physician's financial counselor to get those specifics. If there are 2 embryos of low quality, do most doctors recommend transferring both? Again, I think it depends on what you mean by low quality. If there are embryos that are stage 1 or 2 blast, we might, depending on your age, recommend transferring 2 embryos. But if you're very young and have only done 1 or 2 transfers, I still might recommend transferring 1, at least for your first or second embryo transfer. Grade C embryos, in particular blastocysts, well, embryos at the cellular stage, if you're having a day 3 transfer, or blasts that are grade C, have a lower implantation rate. But it doesn't mean that those embryos will not implant. And that's always the conundrum. If, that's the only embryo that you have, I would transfer it, because sometimes those embryos do implant and do result in pregnancies. They don't freeze well, which is why we don't freeze them. With morphology 0% for my husband's latest semen analysis. Prior to that, it was 12% normal forms. Motility has fluctuated. Do we have good chances of success with IUI or IVF? This patient is a 32-year-old and her husband is 46. So with morphology that is fluctuating, I think first you have to look at, are there factors that could be responsible for this fluctuation? Has there been a recent illness? Is the male taking any medications that might affect sperm parameters, such as androgens or antibiotics or those sorts of things? Is there a structural issue? So usually when there are abnormalities in the semen parameters, a urology consult would be warranted. But if the morphology and motility has been fluctuating, you can try IUI. There's nothing to be lost in trying IUI. If it's not successful, I wouldn't do 6 to 8 cycles. I'd probably do 2. And if that doesn't work, then I would move on to IVF. If the morphology is persistently 0 or 1%, that's an indication probably to go to IVF sooner than later with intracytoplasmic sperm injection. And again, would encourage a urology consult just to make sure there are no other structural abnormalities. Sorry, every time somebody adds something, my screen flips. I had a vasectomy in November 2015. Right now, there is a chance. Is there a chance to have it reversed? So with vasectomies, I think the longer that you've had the vasectomy, my understanding is that the less likely a reversal is successful, but it's not unreasonable to at least meet with the urologist who is very experienced in doing these vasectomy reversals to have a consult and see what their experience has been. Oftentimes what I will find is that men will have the vasectomy, but at the same time, we advise them to freeze any sperm that is able to be harvested at the same time, so that in the event the vasectomy scars over again, there's frozen sperm available. The alternative, depending on how many children you think you want to have, is to just have an epididymal sperm aspiration, freeze sperm without having the vasectomy reversal, and use that sperm for IVF. One of the challenges that many patients have is once you've had any sort of sterilization procedure, vasectomy, tubal ligation, even if you had insurance coverage, more than likely you won't have insurance coverage for IVF after a reversal or after a tubal ligation, unless you can demonstrate that the sperm concentration, motility, and morphology are all perfectly normal post vasectomy, and then you have had to try for a year, and that's a hard bar to reach. if you are going to have a vasectomy reversal or an epididymal aspiration with sperm freeze, and I would make sure that you have that procedure with a urologist who has infertility, whose focus is infertility patients and has a lot of experience doing those procedures. Do we have a standard transfer protocol for all patients, or do you have a tailored protocol based on patients' fertility diagnosis? There are guidelines for the number of embryos to transfer that are national guidelines, and we follow those guidelines. So for women less than 37, the recommendation is if you have one healthy blastocyst to transfer one blast for probably the first 1 or 2 IVF cycles and all frozen embryo transfers that result from those IVF cycles. And then as women get older, the guidelines are a little bit more lenient. So untested embryos at 38, you can transfer 2. But if you've done PGT testing, you would transfer 1. Or for that matter, for anybody who's done pre-implantation genetic testing where you're transferring in a euploid embryo, we would recommend transferring, in most instances, 1 embryo. And then, if there have been multiple failed implantations, then discussions can be had about whether you increase the number of embryos to transfer. The biggest concern with multiple embryo transfer is when an embryo implants, if the environment is right and you've got the right embryos, you're just increasing your risk for multiple pregnancy, and the risk of multiple pregnancy are not insignificant. And we've been able to take our multiple pregnancy rate down to pretty much less than 1% in women less than probably 37 by following the stringent guidelines. What are the best ways to prepare for a successful egg retrieval? Should we take prenatal vitamins, focus on abstaining from alcohol? So I usually recommend a very healthy lifestyle. I don't advise people do things that are, crazy, like, eat, be vegetarian or something like that, because I think that's a bar that's not reasonable to reach. We do encourage prenatal vitamins with folic acid, and most prenatal vitamins have vitamin D and folic acid in them. Certainly during a cycle, I would recommend not drinking excessive alcohol. A glass of wine or so, occasionally during the cycle would probably be okay. We are cautious in terms of how much exercise you do, just because as your ovaries are getting larger, they're uncomfortable, and sometimes you increase your risk for ovarian torsion if you're doing a lot of high impact exercise. And recognize that for an IVF cycle, for instance, the stimulation is about 2 weeks, and then the post-op recovery, with ovaries that are enlarged, takes about 10 days to get back to normal size. So, listen to your body and don't do anything that causes undue stress. But there's no specific fertility diet necessarily that you need to follow, as long as it's a well-balanced diet. What HCG number do we look for after embryo transfer? In most instances, we're looking for an HCG after embryo transfer, the initial HCG that's around 100, and then within 2 days, it typically increases, it typically doubles. So we usually do an initial beta and then repeat it 2 days later. That is, while that's kind of what we would expect, there have been normal pregnancies that don't necessarily follow that same curve. So we may follow those pregnancies a little bit more closely. If you transfer 2 embryos, or if an embryo splits, then the HCG levels are going to be a little bit higher. And then sometimes even a singleton pregnancy will produce higher levels of HCG, and that's considered normal. But in general, the first beta should be around 100 or so. And then the question is, how do you pick sperm from a sperm bank? There are a number of commercial sperm banks, and they all have on their website what their screening is. And it's pretty standard. You know, in addition to doing just a general health screen, the donors should be screened for infectious diseases, so hepatitis B, hepatitis C, HIV, syphilis, cytomegalovirus. They will have genetic screening, and the genetic screening panels will vary depending on how long the donor has been in the donor bank. So years ago, they might have only been screened with a karyotype, cystic fibrosis, spinal muscular atrophy, and hemoglobin electrophoresis. And then targeted ethnic-based genetic screening. So if they were Jewish, they would have the Ashkenazi Jewish panel. If they were Asian, they might have again, a hemoglobin electrophoresis. Now you find that the donors have a more extensive genetic screening. I know that we require that before you purchase a donor, or we ask that before you purchase a donor, we review that donor's genetic profile so that we can make sure that the donor is a good match for you. And so, and what I mean by that is I'm not so interested in their, you know, personal characteristics about education and such, but I want to make sure that if you are CMV negative, that the donor is CMV negative. If you are CMV positive, the donor can be positive or negative. If you are not a carrier of any genetic conditions, then the donor could be a carrier of an autosomal recessive condition. But if you carry one, let's say if you're a carrier of cystic fibrosis, you can't be matched with a donor that's a carrier for cystic fibrosis. So those are the things that we look at. You know, other than that, I think you look at personal characteristics that are appealing to you, whether that's height, hair color, race, ethnicity. And I think that's a personal determination. Let's see. Oh, the other question about donors is, are we concerned since the donors are paid about the quality of the sperm? And in order for a donor to be accepted in a donor sperm bank, his sperm is, he has to produce a sample that is normal and that freezes and thaws well. So they do that test before they accept that individual as a donor. That being said, there may be an occasional vial that's not a great vial, and most of the donor agencies have guidelines so that if you get a sperm sample that doesn't meet a certain number of sperm post-wash, they will usually replace that vial at no additional cost. So, you know, kind of just read all of the fine line details in the contract. Does IVF have a higher success rate than IUI? In most instances, yes. And that's because with IUI, we can't guarantee that the sperm reaches the egg in the fallopian tube. You know, you can ovulate, the tube may not pick up the egg. There may be some subtle adhesions that we're not aware of. Whereas with IVF, we know we have an egg, we have an embryo. I'm sorry, we have an egg, we have sperm, we can create an embryo. We know that embryo is developed, and we know that we're putting it into the uterus, so that the implantation rate of an untested embryo, let's say in a 35-year-old, is about 35%. IUI in that same individual might be 10 to 15% per cycle. So it's just, you know, more invasive procedure, but it also is associated with higher success. If you've done, excuse me, I'm just recovering from a bout of laryngitis, so I'm amazed I'm talking today at all. If you've done IVF and had a smooth pregnancy and delivery, how soon after birth can you try for another frozen embryo transfer? So the American College of OBGYN recommends that patients space their pregnancies about 18 months. That being said, we are, you know, acutely aware of the fact that for patients who are struggling with infertility, that's a long time in between pregnancies, number one, and many patients, you know, are older. So if you wait 18 months, you know, you may have difficulty. So as a general guideline, and I think one of my fellows looked at this and found that in patients who had vaginal deliveries that were uncomplicated, somewhere between 6 months to a year at the earliest would be the earliest that I would recommend trying again. I try to get people out towards at least a year because your body really needs to recover after pregnancy. If you've had a cesarean section, I would not really resume treatment before a year, and year to 18 months is a little bit more reasonable. Can we speak to the egg retrieval process and what women should expect as far as physical feelings, bloating, weight gain, in addition to limited exercise movement during the end of injections and 2 weeks post-retrieval? Every woman is going to be different. Some women have no symptoms, but in general, the gonadotropins cause your ovarian follicles to grow. So the ovaries are bigger, so they may be uncomfortable, and you may have a sense of pelvic fullness. You're producing a lot more estrogen. So breast tenderness, bloating, mood swings, just kind of emotional lability might be something that you experience. There are shifts of fluid. So a lot of women complain of constipation and just feeling just overall fatigued. And then after the trigger shot causes the corpora lutea cyst to produce progesterone. And even after we've aspirated those cysts, they refill with fluid, refill with some blood. And there can be certain growth factors that and other factors that cause leaky capillaries, so you can accumulate fluid in the pelvis and be at risk for the ovarian hyperstimulation syndrome. So, and that can be associated with bloating that can last as long as 2 weeks. The issue with regards to exercise is exercise further fluid depletes you if you don't stay well hydrated, and your ovaries are enlarged. If you can imagine, if you're a runner or you're doing gymnastics or anything like that, the ovaries move and they hurt. So, you have to use kind of common sense and listen to your body and recognize that your ovary is not going from the size of a walnut with one 3 centimeter follicle on it, but it's going from the size of a walnut to maybe the size of a grapefruit in your pelvis that doesn't change size, and those ovarian follicles are uncomfortable. Likewise, post-retrieval, there's some bleeding into the abdomen, which causes irritation. And so in general, I would just say, listen to your body, don't overdo it for 2 weeks, and you can resume normal activities, typically after the first period. Regular supplements that we recommend to support healthy fertility in those with lower ovarian reserve. I think all women should be on prenatal vitamins. There is controversial evidence about vitamin D, but I think that there's no question that if you have normal vitamin D levels, you can eliminate that controversy. So, supplementation with vitamin D is reasonable. And usually everybody in the Northeast is vitamin D deficient just because we don't have a lot of sun around. So 2,000 units of vitamin D daily is probably sufficient to keep your levels in the normal range. For older women, usually over 37, 38, we will oftentimes, and for women with diminished ovarian reserve, we'll recommend coenzyme Q10, which is a cofactor that is involved in the energy pathway of mitochondria, which tend to be the energy source for embryo development. So that may help embryos develop to blast. There is some very soft evidence to support that. But coenzyme Q10 is also used as a supplement for other health conditions. It doesn't have any adverse effects. So it's one of those things that does not do any harm. I don't typically recommend a lot of the other supplements, DHEA, growth hormone, etc. I think that there are associated risks with those medications, and again, not a lot of evidence to support their efficacy. Sorry, the question is, How do you prepare your body to freeze eggs or an egg retrieval? I think I just answered that question in terms of, so I won't go over that. Another question is, does PGT-M testing reduce the quality of an embryo? PGT-M is the testing that we do in instances where we know the couples are at risk for conceiving a child with a known genetic abnormality. So for instance, if both parents are carriers of cystic fibrosis, which is one of the more common genetic autosomal recessive genetic conditions, they go through IVF after there's been some extensive testing to make sure that we can identify both the male and the female genetic abnormality. We screen their embryos and do an embryo biopsy. By doing an embryo biopsy after they've gone through the IVF procedure. And that embryo is tested to see whether it's a carrier of cystic fibrosis, whether it is unaffected, or whether it is affected. And in most instances, embryos that are affected with cystic fibrosis, meaning that they've inherited the two genes, one from mom and one from dad, those embryos we would recommend discarding. Embryos that are carriers or embryos that are unaffected, we also would then screen them to make sure we know whether they are chromosomally normal from the standpoint of numerical chromosomal abnormalities. So that's the PGT-A for aneuploidy testing. And those embryos that are either unaffected or carrier and euploid, meaning that they have normal 46 chromosomes, either male or female, are eligible for transfer. The studies I think that have been done have shown that embryo biopsies at the blastocyst stage do not result in lower implantation rates of embryos. So I would say no, the testing does not further damage the embryo. So I think that if you need to do that for either an autosomal recessive disorder or for those individuals who are where one partner is a carrier of an autosomal dominant disorder or an X-linked disorder, PGT-M will not further damage the embryo. Are there higher success rates doing a fresh transfer or frozen transfer? And is a fresh transfer done in the same cycle? So if you do a fresh transfer, you're doing the IVF stimulation and then transferring the embryo 5 days after the retrieval. Depending on whether or not, I think that there is some evidence that fresh transfers may have lower implantation rates, and that's because in many instances, progesterone levels rise towards the tail end of the follicular phase and start to advance endometrial development. There's also just a general overall higher endocrine milieu, which might have an adverse effect on implantation. That being said, we still have really good success rates with fresh transfers. And it's in some instances, just going directly to a frozen embryo transfer without a good indication, we don't typically do. We typically reserve frozen embryo transfers for those patients who either do the genetic testing or if they have a risk for hyperstimulation where we feel like we should freeze all of their embryos, or if their progesterone on the day of HCG trigger is over 1.5. One of my former colleagues did a study looking at implantation rates with increasing levels of progesterone, and the implantation rates start to fall when the progesterone level rises above 1.2. So if you're not having progesterone levels tested, you may not know that. But they don't really significantly fall lower than what our frozen embryo transfer rates were until the level was over 1.5. So I don't think it's wrong for those patients or for those practices that do all frozen embryo transfers, but I don't think it's absolutely required. The next question is, I'm in my early 40s and would like to get an assessment of my fertility and how healthy my eggs are. What's the best way to do that? And is that process covered by insurance? Typically, I would say yes, diagnostic testing should be covered by your insurance. Just to understand ovarian reserve, women have their best ovarian reserve when they're very young. And as they get older, the number of eggs that they're able to produce is reduced. And the quality of the eggs changes with aging, with reproductive aging, so that if those individuals produce embryos, the risk of chromosomal abnormalities increases. So even women who are 40-year-old women who have good ovarian reserve in terms of number of eggs, they still have a higher propensity towards more of their embryos being chromosomally abnormal, and we can't really test for that. But we can at least do the ovarian reserve testing so you know whether you would be a good responder or not. Let's transition to egg freezing. Patients interested in egg freezing, do we recommend genetic testing prior to egg freezing? And then the question right after that is, how many eggs would you recommend for egg freezing for someone who's 37? So in terms of egg freezing in general, egg freezing is available either to be done electively or as part of a fertility preservation, typically for oncofertility for women who are undergoing who are going to be undergoing chemotherapy, which would render them sterile. In terms of genetic testing prior to egg freezing, we do not typically do genetic testing prior to egg freezing. It's expensive testing. We would do genetic testing before utilization of those eggs. Again, if we're doing genetic testing, the only thing that it's going to tell us is you're probably a carrier of, and it's probably a carrier of an autosomal recessive disorder. And then that just informs us that we need to check and make sure your partner's not a carrier. In terms of the number of eggs that are recommended to be frozen, there have been a number of studies looking at this, and the general recommendation is that it takes about 14 to 15 eggs for one successful pregnancy. If you think about the fact that you thaw the eggs, 95% of them survive, you fertilize the eggs, there's a 70% fertilization rate, and then maybe 40 to 50% of those successfully fertilized eggs go to blastocyst. And then of those blasts in young women, maybe 20 to 30% are chromosomally abnormal, but then women, as they get older, that percentage increases. So there's a fair amount of attrition, I guess is what I'm trying to say. So usually the recommendation is somewhere between 20 to 30 eggs. I think women under 35 having 20 to 25 is probably a reasonable number. In women over the age of 37, you probably need closer to 30, maybe even more. I think you have to look at egg freezing as a option to extend the length of time that you might be able to try to conceive, but I would not look at it as the only way to have your children. So I think, in most individuals, I would encourage you to think about how many children you want to have, what your timeline is to try to build your family, and try to, use your frozen eggs as kind of backup, if you will. Next question. Do we have a standard transfer protocol? I think I've answered that question. The only thing that I would say in addition to what I've already said is for embryo transfer protocols, we typically use either a natural or modified natural cycle to transfer embryos or a hormone replacement cycle. I think for most people, the go-to is the natural or the modified natural, except for those women who are either anovulatory or who have difficulty or who want to time their embryo transfer on a certain day. And then in women as they get older, sometimes we go more to a hormone replacement to make sure that the endometrium is adequately stimulated with adequate amounts of estrogen. My AMH was 1 last year and is now 0.71. Is there a point when AMH is too low to try IVF? That's a hard question to answer, only because while the AMH is a sensitive marker, I've had people with AMHs of 0.5 who've responded and gotten 5 follicles, and then other women with an AMH of 0.5 who've not responded to treatment at all. So, I look at AMH, antral follicle count, depending on your age, sometimes your FSH. And if we do an IVF cycle and you don't respond, I think I'm more likely to recommend moving on to donor egg sooner than later. But would oftentimes, give somebody at least one opportunity to try with their own eggs first, just so that we can be sure that we're not going to get a response. An AMH that's less than 0.1, it's very rare that somebody's going to respond to gonadotropins. Other questions? Going back to egg freezing, a 37-year-old interested in having 2 children and wants to freeze eggs. How many retrieval cycles? A lot of it's going to depend on your ovarian reserve, but if you want to target at 37, I would start targeting closer to the higher number of eggs, 30 eggs at least. That might take 2 IVF egg freeze cycles to do that. Whereas someone who is 30 and gets 22 eggs, they may have enough with 1 cycle. So I think it just varies. One thing we've not really, I guess there's some open questions. Maybe I've skipped over some of these. This is a question. My husband has taken Clomid for 3 months and his semen analysis actually got worse. Could it be a reason to have such an adverse effect to have less sperm count and no morphology? I'm not a urologist, but what I will speak to is the mechanism of how Clomid works in men and what we expect Clomid to do. So in men with low sperm counts and then who have had an evaluation by a urologist, the urologist will typically check FSH, LH, testosterone levels, maybe thyroid and prolactin, to get an overall sense of what the hormonal profile is. Really the same hormones that are tested, but in women. In men who have low sperm counts and low testosterone, with FSH levels and LH levels that are in the normal range, those men may, or in the low to normal range, those men may respond to Clomid. And the way Clomid acts is it, again, Clomid blocks the estrogen receptor, which then makes the pituitary in men respond and try to produce more testosterone, which boosts LH production, and more FSH, which boosts sperm production. So most men who are, placed on Clomid should have improvements in sperm parameters. I think the question is, you just need to make sure there are no other factors going on that could be responsible for the semen parameters getting worse after 3 months. The other thing you have to realize is, I'm not sure what you mean by worse. So if it's a difference in, it may just not be getting better, because semen analyses counts and motility fluctuate. If it's within, a certain couple of points, it may not make a difference. It may not be that different. But I would suggest making sure that, you're under the care of a reproductive urologist. Other questions? My first pregnancy ended up in a corneal pregnancy. Is there a high chance for me to have another one when I try IVF next? And what are the reasons that cause an ectopic pregnancy? So ectopic pregnancies, if you think about female anatomy, the fallopian tube attaches to the uterus, and a portion of the fallopian tube is within the muscle of the uterus, right in the corner. And that's where a corneal pregnancy happens. So if the embryo happens to get stuck in that corner, it grows, but it's surrounded by myometrium, but it's not in the uterine cavity. And it's at high risk for rupture. Typically, when those corneal pregnancies are managed, they're either managed surgically, and you wedge out that section of that tube, or they can be managed medically where you take methotrexate. And in that case, if the tube is still open, there is a small risk of a corneal ectopic occurring again. Ectopic pregnancies typically happen in the fallopian tube, so they get through the cornua and get into the tube. And with IVF, sometimes the uterus contracts and pushes an embryo that was delivered to the uterus back into the tube, and it's too big to get back out. And then you have an ectopic pregnancy. And usually either that's the case, or usually there may be adhesions or scarring in the uterus from a previous infection that might increase your risk for an ectopic. I've had patients who've had 2 corneal pregnancies. And with the second one, we made sure we resected that area out and repaired the uterus so that that wouldn't happen again. It is a risk. I think you have to manage the embryo transfer by making sure you're not placing the embryos too high, but you can't control the uterus contracting and pushing the embryo where it wants to go. What is your take on using Myo-inositol for patients with PCOS? Patients with PCOS who are insulin resistant may benefit from Myo-inositol, as it works in part of the insulin pathway to improve insulin resistance, which may then reduce insulin levels, and sometimes insulin drives higher LH and androgen levels. So I think there's some benefit. We oftentimes recommend a supplement through a pharmacy called Theralogic, called Ovisitol, but there are other supplements that are equally as good. What's the difference between a natural FET versus a medicated FET? I might have addressed this. A natural FET monitors your natural cycle, monitors the estrogen rise, the follicular development. We use a trigger shot with HCG to cause the follicle to ovulate, which then produces progesterone, and we supplement the progesterone and transfer the embryo on the 7th day after the trigger shot. You can use letrozole or Clomid to do a modified natural cycle for those patients who may not have as robust ovulatory cycles. A medicated cycle, you're taking either oral or transdermal or transvaginal estradiol to stimulate the endometrial lining to develop. And then when the lining gets somewhere between 7 to 8 millimeters, you add progesterone in the form of either intramuscular or a combination of intramuscular and vaginal, typically, and transfer the embryo after individuals been on progesterone for about 6 days. Not sure I understand this question. What determines having twins through IVF? Is it the number of embryos transferred? Is it something I can ask for or recommended? She's over the age of 40. And then if we're talking about using an egg donor, does that change my answer? So again, this speaks to our overall goal in IVF is to have patients have a healthy pregnancy, and ideally a healthy singleton pregnancy. That being the case, if you transfer one embryo, depending on where you read, the risk of an embryo splitting and becoming a identical twin pregnancy as anywhere between probably 1 and 5%. If you transfer 2 embryos, especially 2 embryos that have been someone who's very young, or 2 embryos from an egg donor, the implantation rate of those embryos is much higher and the risk of twins is much higher. Typically, we would only recommend transferring 1 embryo. Similarly, if there's been pre-implantation genetic testing, we would only recommend 1 embryo. If you were 40 and transferring embryos that were not trusted, then we would transfer 2. Our goal is really not to help you conceive twins, because we know that although, everybody sees twins in the public and they're all, cute and everything like that, the risk of twins is still fairly high in terms of delivering preterm, ending up in the neonatal intensive care unit, having major medical complications. So to the extent that we can reduce that, that's our goal. Do you typically see the same number of eggs retrieved if someone does back-to-back cycles before a transfer? Again, it varies. I think that a young woman with normal ovarian reserve, so someone, let's say, less than 38, probably would have a similar response from one cycle to the next. That doesn't mean that every cycle she's going to get 15 or 20 eggs. She might get 12 one cycle and she might get 16 the next. That's not a huge difference. There's a lot more variability in women who are much older. And certainly, if you have a poor response, your physician will either look at, could the dosing be modified, or should we change from one protocol to the next? And there are some protocols that, are standard go-tos, which is typically the antagonist protocol, with individuals who have diminished ovarian reserve, who are poor responders. We might either start off with a luteal estrogen protocol, which starts off the stimulation by either placing an individual on a birth control pill before a cycle, or a low-dose birth control pill before a cycle, or estrogen in the late luteal phase of the cycle before the actual stimulation cycle, to try to synchronize follicular development, or a microdose Lupron protocol. So, we do change protocols depending on whether we think we can improve upon the response. Sometimes it works and sometimes it doesn't. But I think for most normal responders, our go-to is the antagonist protocol. Question, I'm 44, hoping to try with my own eggs. Do I have any tips or advice? I think the biggest question to answer at 44 is whether or not you have ovarian reserve that's going to really allow you to try and respond well. The likelihood of pregnancy at 44 is probably not much better, not much higher than 4 to 5%, even with women who are really, really good responders. So, I've had women who are 44 who've undergone IVF, and we've gotten 20 eggs and tested them all, and they've all been aneuploid. So, yeah, we get lots of eggs, but the quality is very poor. So many of the insurance companies will not authorize IVF over the age of 44 for that reason. A similar question is, many of the eggs start off to look pretty good and then they seem to arrest in development, and that's because many of the eggs are chromosomally abnormal and just don't have the capacity to continue to develop and divide. I think we're at the end, and I know that there are a lot more questions. Feel free to send the questions in or attend our next webinar. And thank you all for attending. I would encourage all of you to watch the State of the Union tonight. One of our colleagues has been invited as a guest to the State of the Union, and there are a number of issues related to fertility treatment and care that may be addressed tonight. So I hope you tune in.